I think Karen is sending the link to David to his email.
All right, so then we can get started, right?
I think so, yeah.
Yeah, thank you, Hala. Thank you all for joining us in this breakout session on knowledge exchange. We will have four guests, four speakers today, who will be giving us both a look back on how COVID has impacted their partnership work, but also a way forward on how they think the innovation and the experience accumulated during this very strange and unique year will change the work in the partnerships, and how this innovation might actually make partnership work different. So we have our first guest is Dr. Joe Gallagher from Ireland. Hello, Joe.
Hey, Claudia, how are you?
Hi, how are you?
Good.
Joe is a general practitioner in Goree, Wexford, and his practice has been involved with a partnership in Malawi with the St. John's Hospital in Mzuzu. And their focus is on non-communicable diseases, particularly on hypertension in the last few years. And Joe is also the cardiovascular lead with the Irish College of General Practitioners. Thank you, Joe. By the way, before we start with each presentation, just a quick reminder to the speakers: we will have 10 minutes for each presentation, and then we will go into the discussion. So we have until 15 past noon, and I will remind you 2 minutes before that time. All right?
Great.
Thank you.
Can you see my screen okay?
Yes, it's perfect.
So thank you, Claudia, and thanks everyone for joining us this morning and to discuss what the next 12 months brings. And it's nice to be looking forward out of COVID again. I'm going to discuss a project called Compass Matima that we've been involved in, which stands for Collaborative Medicine, Pharmacy and System Services for the Heart, with Matima being the Chichewa word for heart. And as Claudia mentioned, our partnership is between St. John's Hospital in Mzuzu in northern Malawi and the very exotically named Palms GP Surgery in Goree in County Wexford, which is on the east coast of Ireland. And our focus has been on non-communicable diseases, particularly on asthma and rheumatic heart disease, and more recently on hypertension. If you were at the meeting last year, you'll have heard my colleague Peter Harrington talk about our pivot towards COVID-19 and our intention to create a series of educational videos that could be disseminated by WhatsApp and social media to our colleagues in Mzuzu. And we were successful in creating these with our partners here in Ireland and in Malawi, but they went far beyond our wildest dreams and now have been viewed over 2.3 million times across Africa, and was a real lesson to us about the power of social media. But we know that although COVID-19 thankfully has not affected Malawi to the large degree that we feared at this time last year, it has had a major impact on other health services, and in particular on services such as non-communicable diseases. And this is a WhatsApp message from our colleague Hastings Conway in Mzuzu, highlighting the high disruption of all other services and life in Malawi by the COVID-19 restrictions. And this is something we've seen across the world. I'm sure everyone here in every country has seen disruption to essential health services. And the World Health Organization has highlighted this, particularly for non-communicable diseases. And we can see here in this survey of 122 countries that indeed hypertension management has been quite severely disrupted, with 53% of countries reporting either a partial or complete disruption of hypertension management. Now, hypertension is never going to make it onto a medical drama on TV. It's not a very exciting condition in terms of medical drama. Most people are asymptomatic, and when you treat them, they don't feel all that much different afterwards. But in terms of something that will have a major impact on people's lives and prevent major morbidity and mortality, there are very few things like hypertension that will have such success if detected and treated appropriately. And so it's important to remember that high blood pressure is a cause of over 7.6 million premature deaths each year. The prevalence of hypertension is highest in Africa, and indeed almost 80% of all cardiovascular mortality occurs in low and middle income countries. And looking at some place like Malawi, and this is from the Non-Communicable Disease and Injury Report in Malawi, which was published 2 years ago, you can see here as regards hypertension, less than around 5% of facilities in urban areas and only 1 to 2% of facilities in rural areas have the drugs and equipment to diagnose and treat hypertension, even though these are relatively cheap and inexpensive drugs and equipment. So there's quite a lack of focus in terms of hypertension because there's so many other competing priorities in countries like Malawi, and it falls off the page. So this came to our idea of the COMPASS community, which we recognize that although hypertension is there, although we have effective diagnostics and treatments for it, perhaps we need to work out the system better. And this is an idea that Mark Ledwidge, you'll see here, who's a professor of pharmacy in Trinity College Dublin came up with. And we created a COMPASS community, which involved not only clinicians in terms of nurses, pharmacists, clinical officers, and doctors, but also health policy and health managers and local communities to decide how can we best diagnose and manage hypertension in Malawi. One of the big problems we had noticed when we looked at what was happening in Mzuzu at the time was that there was frequent stock out of drugs. There was 12 to 14 drugs being held in the pharmacy because you didn't know what drug was coming next month. And that led to a lot of uncertainty among both healthcare workers and patients around what drug they were taking and when. I'll talk a little bit more about how we looked at how we might ensure these costs going forward. But we felt it was very important that we could ensure a sustainable supply of drugs and treatment going forward. As I mentioned, we looked at the formulary and found that also that there were older drugs being used, and these weren't necessarily cheaper. Sometimes we said, oh, they're older drugs, so they may be cheaper, but they weren't always, and often people had to take them more often during the day, so compliance with medication was less. And with no defined protocol for review or management, different people did different things. So we worked on how we can manage that. And that led to training and support, which I'll talk about in a second. And we felt it was really important that we monitored what was happening, and we learned from that and changed as we went along. And what we came up with was from those 11 or 12 drugs that were in the pharmacy, we got it down to 4 different types of drugs. And that allowed us to partner with Action Media, a German charity focused on pharmaceuticals, to ensure that we could source good quality, sustainable supplies in Africa for these 4 drugs. And also there was a standard treatment regime that would be followed by everyone in the clinic. And so that ensured that the patients would get the same drugs every month, that if you came in on medication, the healthcare worker also knew what drugs they were going to prescribe. And crucial to this was having what we call the Hypertension Heroes. And you'll see 2 of them here. This is Hastings, the clinical officer I mentioned, and Lillian, the nurse with one of the patients, who really promoted this across the hospital. Made people realize how common was blood pressure in Malawi, the effect it had in causing almost half of the strokes and heart attacks. Hastings also led workshops in the hospital to advise people of the changing protocol and why we were doing it and the importance of adhering to it and detecting and diagnosing hypertension. And more recently, with the support of Esther, we've also been able to develop an e-learning platform on Moodle, which allows people to view these at home. They can download this lesson within the hospital on the broadband there, go through the lessons at home, upload data and answer questionnaires, and so have a community, a virtual community also for the hospital in this regard. I suppose, what does this look like for a patient? And so this was Gertrude, who was a 66-year-old lady who came to the hospital for her hypertension treatment for over 11 years. She was on 3 different types of medications, but was taking 6 tablets a day, spread over 3 times a day because of the dosing and the regime was. The best cost we could get at the hospital for this sort of regime would cost around €25.80 over a year. And so using the COMPASS formula, we were able to amend her regime. So now Gertrude still takes 3 different types of tablets, but only takes them once a day, which helps her in terms of having to just take them in the morning. But we've been able to almost halve the cost also. So we've improved the outcomes for Gertrude in terms of she has better control of her blood pressure. She doesn't have to take as many tablets. But also in terms of the hospital, they've been able to reduce the cost to them of actually supplying these medications by focusing on a limited number of medications and ensuring a supply over the year. And so what have been the results overall of this? I suppose we just, in the last 2 weeks, we've got some early data on this. We do see all these people were on treatment before the clinic, and the blood pressure control wasn't bad at all by any means, with an average blood pressure of 150/89. But the people who are on the COMPASS formulary now, the blood pressure has dropped by around 10 millimeters of mercury and systolic blood pressure using the new formulary. We've also worked out that the cost of treating this is around €1.90 per month, including the medication cost and the clinical cost of the review. And I suppose, what does 10 millimeters of mercury mean in terms of clinical effect? Well, that reduces your stroke risk by around 35% and your risk of coronary artery disease by around 20%. So again, it's about doing things more cost effectively, more clinically effectively, and ensuring that we have consistency of supply. This here is Isaac Zeby, is one of our other key partners. And I suppose one of the challenges is St. John's is not funded to provide NCD care for free to people, and costs of treatment were an issue, and costs of drug supply. In terms of ensuring costs, Isaac highlighted to us that, well, if you're in Mzuzu and a taxi driver, you may have cash, but if you're in rural Malawi, you may not have cash readily accessible. And Isaac's had this concept of goats and chickens, where perhaps, someone in rural Malawi may give a chicken, and that can be sold in the market in Mzuzu to the taxi driver, and those cash then can be used by the hospital to pay for the drugs and care. And as an example, 2 chickens a year will pay for your hypertension care in St. John's at the moment. So this is something that we're sort of developing in terms of a social insurance model about how we can ensure that the hospital can continue to provide this sustainable drug supply and sustainable clinical care at an affordable cost for people. So in summary, these are very early days in this project. It's really a concept at the moment, but we've seen some really encouraging early results. And we hope that we can come back in a couple of years to tell you how we've got on with this. And we'd love to learn from anyone's experience as well, who may have some experience in this area also. So thank you, Claudia.
Thank you very much for this presentation. I'm really impressed by the very good results you can actually document. And I think it's also very, very interesting this holistic approach that you have, that you not only focus on the medical aspect, but also on the financial aspect of care, which I think, of course, in the countries we work for, is not always ensured. Thank you, Joe. And then we will go to our second presentation with Professor Anthea Rhoda from South Africa. Hello.
Hello, I am here. I'm going to share my presentation.
Perfect. Let me introduce you, Professor. Professor Rhoda is Dean of the Faculty of Community and Health Sciences and a professor in the Department of Physiotherapy at the University of Western Cape in South Africa, as I said. And she's also a very active scholar and focuses her research on patients with neurological impairments. And she's also conducting research on faculty development and interprofessional education, which I'm sure is also very relevant in the area of partnerships. So, Professor, if you want to start your presentation, we have, as we said, 10 minutes, and I will remind you by chat. I wouldn't like to interrupt you, so I will remind you by chat after 8 minutes, all right?
That's good.
Yeah.
Good afternoon, everybody. As introduced, my name is Anthea Rhoda, and I'm from the University of the Western Cape in Cape Town, South Africa. Just to introduce my faculty, or the faculty which I lead currently, those are 2 pictures. We have a part of our departments on what we call the main campus, and we've about 2 years ago also moved part of our campus to the Central Bellville district. Just quickly about the faculty, we have departments in our faculty, which includes dietetics and nutrition, physiotherapy, psychology, occupational therapy, social work, and sports science. We have 3 schools. We have a big school of public health in our faculty, also, which is mainly postgraduate, and a big school of nursing, and a school of natural medicine as well. We have a number of centers, which includes child and family studies, sports science, and we have an interprofessional education unit in the faculty as well. Just to add that when we look at our global presence, so today I'm just going to share broadly how we have managed to maintain our international partners during COVID-19. And we've got some strategic partners with a long-standing partnership with the University of Missouri in the US, with Ghent University in Belgium, and then more recently, a partnership with Asahi University in Japan. So just to add, so what were some of the, if we look at when we engage with international partners, and within our faculty, we have health partnerships as well. and social partnerships. One of the things we do when we engage with international partners is around obviously building partnerships. We know staff and student mobility is something we do quite a bit. Collaborative learning and teaching is something that has actually started even before COVID. We do collaborative research projects, postgraduate student supervision, as well as looking at work-integrated learning or service learning activities. Now, why I've actually put a line through the staff and student mobility is because we actually, during COVID, we know that there was no mobility that happened. What we also do as part of international partnerships is that we also engage around facilitating or supporting universities either to set up new programs within their specific universities. Now, when we build partnerships, if we reflect on building partnerships, one of the things that we do is that we build partnerships around a current theme. And if we're thinking about a research project, as mentioned when I was introduced, I've got a research project with Karolinski Institute where we look at the health systems for individuals with spinal cord injuries. And so that is a common partnership. What we actually then did during COVID was with our partners across the faculty, we attended and continue to submit to virtual conferences, and we collaboratively presented at virtual partners. We also found that once we went to these virtual partners, even during, although we could not physically be at the conference, we could still engage and look and develop new partnerships, so really reaching out to others. During the time, we used quite a bit of social media and social media platforms and engaged with collaborative webinars with our partners. We do belong to global networks such towards Unity for Health and the AfriPen, which is the African Interprofessional Education Network, and that also continued or assisted us to help to continue with our partnerships during COVID. In terms of learning and teaching with our partnerships, we have projects where students collectively learn and engage in modules. And one of the modules we have is with a university in the UK with occupational therapy. And we know, colleagues, that ethics is something that is global. And so with occupational first-year students, when we teach ethics, we doing it collaboratively. And even during COVID, because these activities were already online using our learning management systems, those kinds of activities could continue with our partners even during COVID. So I want to say we were starting to prepare ourselves for a time when we could not physically meet. And of course, with this on these platforms, we have peer learning activities as well. Then also to add, we now moved from these types of collaborative research engagement more to virtual collaborative research. And so instead of being physically in a seminar with our partners, we currently partner now and we have virtual and online seminars. Collaborative funding research proposals we continue to do. I spoke about the presentations. One of the things that in our partners we needed to look at more innovatively is how we had to move from our data collection from one-on-one, face-to-face to online interviews. Data sources or secondary data sources that could be used for our collaborative partnering research were things like information that we even could find on a platform such as Facebook. One of the things that became very relevant and a strong consideration when we worked online was around how do we now apply and think about online ethics when engaging online. Just also then quickly to say, with our partners, as part of our partnerships, we also do post-collaborative postgraduate supervision, and these then had to be done online using virtual platforms, and supervisors from different countries had to then give comments on research proposals or research projects using a platform such as Google Drive. Work-integrated service learning, colleagues, again, we know that our study abroad visits could not happen, but one of the things that we started looking at and started speaking about is this creation of virtual communities using 3D models. And of course, we could use case studies as well. So just to reflect a bit on the questions that we were asked, how did we adapt and innovate? we engaged. One of the things we did quite a bit and included our partners was engaging around staff and student wellness during the COVID-19 pandemic. I spoke about virtual engagement. One of the strong considerations was hence now the time zone differences. And a lot of our webinars we actually found had to be done for the South African time later in the afternoon, because that's when some of our partners are only waking up during that time. So it's time zones, and I even found that some conferences, when it was happening, some people was in the middle of the night. The frequency of engagement was a strong consideration with our partners. We had to set very structured times as to when we would engage, and we had to engage on a more frequent basis than what we would normally do with our partners. We also had to think about how we were going to share documents online and develop document sharing repositories using whichever online platforms. The lessons learned, I think, just to re-emphasize again, is that the need for continuous engagement. So in our partnerships, we had to build in mechanisms for continued online engagement. We had to even apply innovative measures in terms of research. One of the projects that was done between colleagues in our faculty and with colleagues in Zambia and Zimbabwe was around a research bootcamp, which they completed the proposal, the data collection, and the writing of the report in about a 6-week time. Very intense, highly staffed, a lot of staff involved, but very focused. And I think the fact that people could then engage online using a webinar or using an online platform actually allowed them to be able to produce something, a document in a very short time. Also, going forward, you know, what role do we think that institutions will play during health partnerships going forward for following COVID? When we think about learning and teaching, I think that tertiary institutions or higher education institutions need to continue to contribute to designing innovative learning and teaching materials, not only for students, but for our community-based projects as well. And collectively, we need to contribute to mechanisms to teach specifically in our field of health. How do we teach clinical skills using online or platforms or the AR, VR, etc. I think collectively we need to be able to contribute to that. Research, I think as far as going forward, we need to continue to look at how we contribute to the knowledge base, so the evidence base about how we respond to aspects such as pandemics, so that we are better prepared, but also in the aftermath of pandemics, all the behavioral and social impact, as well as the clinical impact. So there's quite a bit of research, I think, that we still can conduct. In terms of service and community engagement, we need to ensure that going forward, how we then, through the information of the knowledge from our research, how we do this, share this with our communities through the processes of knowledge translation. Thank you very much.
Thank you so much, Professor Rhoda. This is really very current, all you presented to us. I'm very impressed by the diversity of technologies and tools that you quickly used for training, and I'm also very interested in this new challenge that you already raised, right? The ethical aspect of this new digital era. I think that will be probably something we can discuss in the round later. We just, our colleague Sandra just joined, Sandra Kemp. Hello, Sandra, can you hear me?
Hello, I can hear you.
Perfect, welcome. I'm glad that it worked out, and thank you so much for stepping in really short notice. Unfortunately, your partner in Ethiopia could not join us today because of internet issues. But you will be introducing your partnership work for a very long time. As a nurse, you've been working in Leicester University Hospital and partnering with Covert University in Ethiopia, and you've been providing teaching and trainings to your partners in Gondar and supporting them in topics like health promotion and infection control. We are very thrilled to hear your presentation. You have 10 minutes, so approximately until 20 past noon. I will let you know when you have 2 minutes. I think I will tell you not right, because I realize it's a little bit confusing. I guess one of our colleagues has your presentation, correct?
Yes, I think so.
Yeah, Hala, sorry, we have someone else entering. Hala, do you know who will be showing the presentation?
Yes, Karen will share it now.
Yeah, I'll just share it this way. Thanks,
Oh, yeah, thank you. So, yeah, it will be ready in a minute, I guess. There you go.
Is that coming through okay?
Yes.
Great.
Yes, I can see that. Do you want me to start?
Yes, please go ahead, Sandra. Thank you.
I'm sure everybody's read that. Can you move on to the next slide, please? First of all, the group in Gonda would like to thank everyone that's helped in assisting us to get a grant from THET to set up a training programme. The training we felt most important was for the 300 porters at the hospital who had no knowledge of infection and prevention control before the pandemic. We would also like to thank THET for the Health Worker Action Fund, a grant to help us fight the pandemic. Next slide, please. Finally, they want to show their appreciation, we all want to show their appreciation for Gonda University and the Ministry of Health for their uninterrupted assistance during our effort to fight COVID-19. Next slide. Gonda is in the north of Ethiopia, quite a remote area, but the biggest town, and it serves a population of millions. Next slide, please. That's just a picture of Ethiopia and the closeness it has to the Sudan and Eritrea. Next slide, please. Coronavirus disease, or COVID-19, is a respiratory illness that can spread from person to person. The COVID-19 pandemic has created a multitude of acute challenges for healthcare delivery organisations, including inadequate capacity, supply shortages, the need for care redesign and financial loss. Complexity science views healthcare delivery organisations as complex adaptive systems that did operate in highly complex and unpredictable environments. The perspective assumes that much of the organisation's life is unknowable, uncertain, unpredictable, and therefore cannot be standardised and controlled. Due to the above reasons, our hospital has faced so many challenges. Infrastructure problems designed for isolation needed the new hospital to be rushed through very quickly to enable it to be used for isolation. There was an acute shortage of reagent for COVID-19 tests, and PPE continues to be a problem for them. Health, social and financial problems. To fight COVID as a teaching hospital, we've undertaken the following measures. Everyone's been asked to complete a workplace risk assessment to secure the health, safety and welfare of all staff. Have individual conversations about COVID-19 with all members of the workforce who are found in our catchment area. Follow the Ministry of Health and partner advice on safe working to take the maximum steps to ensure the safety of everyone in their workplace, which we have done. We want them to continue to fight COVID-19, to follow all relevant guidance on how to prevent, control and manage an infection in their care setting. To coordinate fully, to coordinate fully with their public health protection team and other local partners as needed. Want to ensure all care staff have ongoing training on infection prevention and control and the appropriate use of PPE. We want to make awareness to health workers about COVID-19, and the fund that we received from the Health Worker Action Fund from THET enabled us to do this. Testing is a critical part of supporting adult social care in the fight against COVID-19 and helps to prevent and control the spread of infection and outbreaks by breaking the chain of admission. Through our hospital, which is one of the COVID-19 testing centres, we are committed to delivering the testing needed to limit the spread of the virus and to save lives. There are many lessons to be learned from the outbreak and spread of the coronavirus to reach levels of a pandemic. We have found ourselves in unusual, uncertain times. Everyone responds differently to change and uncertainty. Perhaps we could all be served by learning something from others in the situation we find ourselves in. The financial impact of COVID-19 on healthcare organisations. Facts matter, leadership and transparency matter, science matters. The non-discriminatory nature of the virus in attacking humanity across the races, economy, class, gender, sex, pregnancy, marital status, ethnic or social origin, colour, age, disability, religion, conscience, belief, culture, language or birth. We have come to learn that we are all in this together. So our future plan, on behalf of our health partner, in lower resourced countries like ours with populations that live day by day, lockdown is unsustainable. As a result, other measures to reduce transmission will need to be considered. Several therapies improve individual patient clinical outcomes through a variety of effects, including inhibiting viral replication, doing clinical trial research, continue learning by making people more aware. Social workers and other professionals provide psychosocial support. And the role of institutional health partnerships. We need the role of institutional health partnerships in improving healthcare following the COVID-19 pandemic by helping us to solve the financial impact of COVID-19 on healthcare organisations, provide reagents to give training, involve clinical trial researchers, provide vaccines, support people who receive social care, the workforce and the carers. And personally, I'd like to thank Adisu, who's our monitoring and evaluation expert in Gonda Hospital, Yalalet for being the lead for this project and working with me on many, many projects over the years. And finally, Dr. Ashanafi, who's the Chief Executive of Gonda University Hospital. Thank you for your attention.
Thank you, Sandra. I have to say that I'm very moved by your presentation. I found it a really unique moment and almost poetic to have you. We can feel your engagement and we can feel how long you've been working with these partners together. And I just found it beautiful with how much respect and compassion you've been reading this presentation. Thank you so much.
Thank you. Thank you for the time.
Thank you. Last but not least, we have Dr. Sonny Khan, who will be presenting his work with the WHO. Hello, Dr. Khan.
Hello, everybody. Good afternoon in the UK.
Hello. Dr. Sonny Khan is the project lead for WHO COVID-19 Health Service Learning Hub. And as a consultant for WHO, he has been leading multiple projects with a focus on primary healthcare and health systems. Recently, the WHO Primary Healthcare Young Leaders Network, and Dr. Khan has also co-written in the past few years the G7 Primary Healthcare Universal Knowledge Initiative report, and he's a practicing GP in the UK. Hello again, Dr. Khan. We are very thrilled to hear your presentation on the Learning Hub. Thank you. Maybe yeah.
Well, thank you so much. And if I can start by saying what a privilege it is to be part of this forum today. I've listened with much interest this afternoon. And just to echo your comments, particularly with our last speaker, about how inspiring it is to hear about the partnership approach and the dividends it's paying, particularly at this time of the pandemic. I know time is tight, so I will crack on. I think this slide is being shared from your side. Is that right? So we can start with the presentation.
Yeah, thank you. Yeah, there you go.
What I'll be talking about today is a new initiative at the WHO, and this is something that has been in the works for the last few months. It's called the COVID-19 Health Services Learning Hub. It's a new knowledge platform for cross-country learning on maintaining essential health services during the pandemic. But also we are looking to the future and how we can use this moment to inform and strengthen health services in the future. And the reason this came about really is because member states were asking WHO at the time when the pandemic started a year ago for a mechanism to share lessons on how countries were adapting their health services beyond just tackling the virus. So WHO had developed operational guidance on this topic, on how to maintain essential health services in March of last year, and that was updated in June, outlining key operational strategies in which to support countries in maintaining their services. And the HLH, the Health Services Learning Hub, has very much grown out of that operational guidance. And we think that it could be an effective learning tool for responding to this particular moment, and especially how health services are being impacted, as I know as a physician, as I'm sure many of you have heard today about the impact on non-communicable diseases and other areas. We think that now more than ever, this sort of mechanism is important. So if we could just have the next slide, please. So as I mentioned, the focus will very much be on essential health services, but also with a view to look at how we can strengthen them in the future. And our audience for this initiative spans both national and subnational contexts. So this includes COVID-19 incident management teams and planners at the national level, so within sort of ministries of health. But also we're interested in the subnational perspective, particularly from sort of the district level below, on how health services have been disrupted, and also measures that have been taken to address those impacts. And in addition to the country level, we also would obviously have an intentionality on working with technical partners and with other WHO departments as well. Next slide, please. So I'll talk very briefly about how this learning platform will look like. So it is web-based, but the website is very much only a part of the overall architecture. And in the last few months, we have been working behind the scenes with a number of countries and with THET and with partners, including THET, on setting up sort of initial pilot programs around learning on essential health services. And there are 5 main areas. So we are collecting action briefs, which are particularly interesting case studies on how countries have approached maintaining essential health services. They're also coming from partners as well. The action briefs not only highlight what's gone well, but also challenges inherent in sort of the impact on essential health services. We are synthesizing emerging themes in the forms of learning briefs, collating information on essential health services during the pandemic from a wide range of sources in a knowledge hub. And then a key part of the platform are these learning laboratories, which are going to be virtual communities and practice on key topics. And of note for this conversation today, we are very much taking a collaborative approach with this endeavor. and are keen on a broader network of networks being about 20 organizations.
Yes. Yes,
Everybody's mic is on. Would you mind muting? Thank you. So this is just an overview of the website. We are due to launch in the next few days. This is the main launch page outlining those key areas of the architecture. If we could have the next slide, please. And this is an example of a action brief title from the Esther Alliance on how digital platforms have been used in the context of international partnerships in maintaining essential health services. So examples like this will be on the website, and then we will build from that. In the next slide, I'll just talk a little bit about that in a bit more depth. So yes, if we just go ahead and so as I mentioned, we have these action briefs, these case studies, which feed into other elements of the platform. They feed into the synthesis documents in terms of identifying emerging learning themes. And then those learning briefs also feed into these communities of practice or the learning labs on the platform. So we have this learning journey mapped out, taking the information from the case studies and building it so that we can address those needs rapidly. And they're complemented by those two other elements, the knowledge hub, if we just click again, please, and also the network of networks, which I mentioned is this collaborative network of international organizations. Next slide, please. Very briefly, we have worked very hard on establishing organizational links within WHO with other learning initiatives. This includes the WHO Academy, which is a flagship learning initiative being launched this summer by WHO, and also in a broader multi-agency effort, specifically with the ACT-A initiative and the Health Systems Connector, which is a key component of that. Next slide. And, you know, obviously Thet has mentioned, and the Esther Alliance mentioned here as sort of key external partners we've been working with. We are very, very keen on this being a collaborative effort. This is not something we think we can do alone. We very much value the input of all these organizations and more that have been involved in developing the case studies and other elements of the architecture. And we'll be working with them on an ongoing basis over the next few months. Next slide, please. And just on a very last note, I mentioned these action briefs. We have actually on the website and actually prior to that had an open call for submissions. I think Shams may have talked about this earlier on in his presentation this morning. So we have a link which we would like to share with you all on the website about how you can contribute particular interesting case studies on essential health services, and particularly in the international partnerships context. And again, identifying that sort of subnational perspective is of particular importance and particularly encouraged. So that will be available on the WHO website, but we can also send that to everybody on this presentation as well. So that's it for me. I'm happy to answer any questions, and thank you again for the opportunity to present and be part of this conference today. Thanks.
Thank you very much, Sonny. Yeah, I would open the floor to questions. So please, if you have any questions, just put your mic on and go ahead. Thank you. Otherwise, maybe as a warm-up, I would like to hear from all of you. We have seen a lot of innovative digital innovations and new approaches. And I would like to hear what is your impression, to what extent can we really access our partners? Can our partners access, can you in Africa, in Asia, really profit from these digital tools? From what we have seen in our Germany projects, sometimes there are connectivity challenges. Not every health professional has access to internet, and yeah, I would like to know how democratic or how accessible do you think these tools are, or I mean, what will we need in the health partnerships community to make it even more accessible? Thank you.
So it's Anthea. Yeah, I think I want to share just from an educational background, and definitely it would be a consideration with our partnership. So if we are talking about the partnership between, example, say students looking at a specific health matter, we do have some of our students who don't have free access to the internet, and we definitely saw this when we had to go immediately online, remote, fully online. The university had to provide some of the students with what we call data and devices, and so that is something that we have to consider. And sometimes so one would then have the provision might not be sufficient because the network in some areas. So it's definitely, if we are engaging with partnerships and we want to look at, some of so if our students are having those problems, obviously all the patients, the clients, the community members would have similar problems as well. So in some of the deep rural areas, it definitely would be, access is a challenge. Thank you. And at the moment, we have what we call load shedding with electricity, and then all the Wi-Fi disappears. And so that is also a problem. Thanks.
Hello, I'm not the Esther, I am a Esther. In terms of sort of keeping in contact, we've had to try various different means with our partners in Ghana because they're quite rural, but they do have reasonable access to mobile phone networks. So we've tended to use things like WhatsApp or Zoom. Zoom seems to work. I live in the UK. I know I've got no mobile signal where I am at the moment. So it's not just in African countries where there are connection problems. I suppose what I'd like to say at the moment is, can mental health be considered as an essential service? Because I think as we come out of the pandemic, we are going to see a lot of need for mental health services. So I kind of like something in the World Health Organization website to cover how we support people with a mental health crisis that we're going to be heading into.
Thank you, Esther.
If I can just respond, Esther, thank you for your question. Certainly, I think the mental health perspective is incredibly important. I speak both as a GP, but also working in global health, marrying both the on-the-ground perspective and the global perspective with the learning platform. We certainly think that it's an important priority for countries in post-pandemic. We are, in terms of how we're operationalizing that in the platform, is in a number of ways. So things like, if there's anything particular case studies you think that might be relevant, or areas that you would like to highlight, I've just put our email address into the chat box. Please reach out to us, and we'd love to sort of build on that for some of these early case studies and learning discussions. And I can also signpost you to our operational guidance, which talks about sort of broader context around essential health services.
All right, Dave, drop down the stuff to be put up inside them.
Katie Sheehan, do you want to participate? Sorry. We are seeing you now.
I'm on a teleconference here, so I'll ask Karma to go out.
Okay, I think I will try to mute your mic, or Sorry, Katie, are you? No, yeah, now your mic is off. A question from Shams Said from WHO to Sandra Kemp. Excellent to see the focus on porters in Gonda. How was this engagement with these neglected health workers? How was this engagement with these neglected health workers being seen by hospital leadership? Sandra, would you like to respond to that one?
Hello, can
Sandra?
you hear me?
Yeah.
Yeah.
Perfect.
We talked about the trained staff and how we were going to update them. And then it was recognised that so many of the staff who did portering, gardening, all those untrained staff had no knowledge at all of infection control. So that took priority over every other part of the training that we did. And we did 3 days training. And it was absolutely amazing to see the knowledge gained in 3 days by those porters. The monitoring and evaluation report that was done is absolutely incredible to show where they came from and where they ended up. So thanks to the staff in Gonda that did so much of the hard work. It took a lot of planning, a lot of time, and a lot of energy. So we're very grateful that they did that, and the people have gone out and spread the knowledge into the community, not just in the hospital.
Thank you, Sandra. That's actually also a very interesting experience. We have 5 minutes, and I see there's, I would like, instead of summarizing what we said today, I think it would be much more interesting to give you the chance to give a final word. So if you could summarize in a message what we would like, what you would like to communicate to the community, that would be great. So I would start again the round, and again, if you can put in a nutshell a closing message, that would be great. Joe, are you ready?
As ready as I'll ever be.
You're the first one.
So thanks everyone. It's been really fascinating to listen to everyone's experiences and the shared experience that we all have. I think from our project, the thing we've learned is don't be afraid to get it wrong. You know, it's okay to be wrong. It's important to know that you're wrong as well. So it's important that we monitor and know that it hasn't gone right, but it's possible to change. And just because things have been done that way for a long time doesn't mean that you can't do things better and cheaper and more effectively. So thanks.
Thank you very much. That was a great message in such a quick time. Thank you. Professor Rhoda, would you like to give your closing words?
Yes, thank you very much, Claudia. I think we have to reflect on, although it was difficult in terms of suddenly or rapidly having to move into a different space to continue partnerships, to continue teaching and research. There were very good lessons learned from having to work in a different manner or in a different space. And so I want us to reflect on going forward when we are engaging and thinking about engaging with our partners, you know, just to reflect on the positives that we've learned by having to work in a different way. So for example, you know, we to reach our goals, we don't always have to do all of the mobility things, but all of the engagement, specifically, I think, on using the online platforms and the way in which we had engaged during the pandemic, we should continue to kind of apply those going forward. Thank you.
Thank you very much for that one. Sandra?
I'd just like to say that connectivity is often the problem in Gonda, and our communication channels have to vary according to what we need to speak about. But working together is the most important thing, and we did lots of planning, lots of communication to get a good result from our set grant. And we'd just like to thank everyone that's been involved. Unfortunately, today there was no connection in Gonda, so I will report back to them and tell them how good this has been. And hope also thanks to Shams, who I've known for many years, and thanks to his questioning, I was able to tell people why we did what we did. So it's working together, that's the important thing, and keeping in touch.
Thank you very much.
Thank you.
And last but not least, Sonny.
Just to echo what Sandra said about collaboration, I think when we look at what has been said in this forum today and the work that we're going to do with the HLH, working together and collaborating with you all and with other partners is really going to be the marker of success for any initiative like this, and that we should, as has been highlighted today, keep that grassroots perspective really at the core of these sort of global initiatives. So thank you for reminding us of the importance of that, and again for giving the opportunity to speak today, and again to be part of this inspiring session. Thank you.
Thank you all the speakers and all participants for the questions, for the interest, for the presentation, and special thanks also to, I hope I pronounced it well, Ziad and Barbara for the technical support. Without you, it would have not been possible. Yeah, so great session. Thanks everyone, and let's go to the next sessions. Thank you. Bye-bye.
Thank you.